Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Drew Remignanti. He's an emergency physician, and today's Kevin MD article is High Tech Should Not Replace High Talk and High Touch in Healthcare. Drew, welcome back to the show.
Hey, thanks a lot for having me again, Kevin. I appreciate it.
All right, so tell us what this latest article is all about.
Well, I think what we're losing a clear grasp of the importance of is the interpersonal interaction between a patient and their physician. That's being devalued rapidly. It's being replaced by this new model, which is the consumer provider model, which is both more expensive and less effective than a true one-on-one connection with a physician who knows you and who you feel known by.
Now, what are some examples that you see that makes you say that?
Well, all throughout my career, I worked 40 years as a board certified emergency physician, and progressively throughout my career, more and more pressure was placed upon me and my colleagues to see patients, see them faster, keep them more satisfied, and by the way, don't make any mistakes during that process. And what we learn in emergency medicine, I think what we learn as physicians all across the board is when is it time to slow down and when is it safe to speed up when you're with a patient, but when do you need to slow down and truly understand what that patient is trying to communicate with you. Intense pressure to the point of not being directly threatened with firing, but indirectly saying, gee, if you want to keep your job, you have to become more productive. There are no products in healthcare. There's information interventions that are useful and appropriate for the patient, and some that are less useful and less appropriate for the patient. But there are no products in healthcare. And certainly as patients, we don't feel like consumers, or I never did.
Now, when you said that when you were working as an emergency physician, there was more pressure on you and your colleagues to see more patients. Was that pressure explicit? Did administrators literally come up to you or write to you and say, you have to see more patients?
Very much so. I mean, they kept data about how many patients you saw per hour is the way it's done in emergency medicine, probably throughout across the board, how many patients per work hour or per work day in primary care or other specialties. Literally to the point where you need to see more patients. And my response was, I tried to say in a polite way, look, when I'm with a patient, you're not there, it's me and the patient. I need to decide how much time we need to take to have this communication. And obviously in the emergency department, sometimes you need to know there are other people who might need your attention. So balancing that juggling act in emergency medicine is a pretty sophisticated thing. Probably not all that different from what you do in an office practice where you know you have 3 or 4 patients in different rooms, and who do you spend time with and who can you spend briefer periods of time with. And if you're not being productive enough, you're definitely getting bonuses based on how productive you are. And then you're told, well, gee, you're not productive enough and you got to improve that. I was told that every single year during my annual evaluations by my department chairman. It got progressively more offensive as I was 35 plus years into my career. By somebody who was a good doctor. I mean, they were clinically experienced physicians, but far less experience than I had. And when you're not in the room there with me and the patient and looking at it from the outside saying, you need to spend less time with that patient, Drew, I had to be fairly stick to your guns and say, no, that's for me to decide.
Now, what were some of the repercussions if you weren't as productive as you would like them to? Did you see that your colleagues would lose their jobs because they weren't productive enough or they didn't see enough patients?
There was that constant pressure there. And I had a progressive concern towards the end of my career. I decided at a certain point that I was going to try to make it working full time till 2020 because I graduated medical school in 1980. So that was my goal. So I thought, gee, I'd hate to be fired at the very end of my career because I wasn't productive enough. But much more important to me was spending the amount of time I needed to with each patient. And in my book that I wrote, I described several patients that I came whisker close to making a life-threatening decision on the basis of making the wrong decision. It would have been life-threatening to that patient. So it was a constant pressure.
Now, your article talks about the infiltration of technology into that doctor-patient relationship. So, overall, before we dig down into that, do you think that technology has helped or harmed the doctor patient relationship over the years?
I think it's helped us to come to more accurate decisions and treatment plans with our patients. I mean, I wouldn't trade the high tech at all, but it has to be, it's a tool that's used. It doesn't necessarily promote the patient physician relationship, but it can be used as an effective tool in coming to the right decision for your patients.
Now, what are some examples of high tech or tech tools in the emergency department setting that has most impacted the field over the decades that you've been practicing?
We've become much more sophisticated in our X-ray imaging, for example. The CT scans were a novel thing during my training, and a lot of hospitals just didn't even have a CT scanner. And you had to decide as an emergency physician, is this patient safe enough, and is it in this patient's best interest to put them in an ambulance and transfer them to a facility that has an actual CT scanner to further investigate this condition? And sometimes you had to do that. And if you had an unstable patient, it became a difficult decision. What's more important, stabilizing and keeping an eye on the patient right next to them or sending them off in an ambulance? Now, every hospital has a CT scanner, and many have MRI scans as well. And you get much more sophisticated imaging with an MRI scanner and a CT scanner over a plain X-ray. So that's been an amazing improvement. However, whether it's being overutilized, I don't think anybody would argue with you that it's not being overutilized. And you can actually, this is a funny thing I came across the other day. You can actually order your own total body MRI scan from literally from head to toes. They'll scan your entire body. You don't even need a physician's order. You can just have to have the money, $2,500 it costs to get that done. You have to have the money and desire to do it and the anxiety that you think is going to be put at ease. So that's an example of a tremendous improvement of X-ray imaging, but being misused by patients who want what they think is going to be the reassurance of having that scan appear normal. What they don't understand, of course, is that sophisticated imaging picks up minor things. Incidentalomas is the medical term that we jokingly use. An incidental finding, a little collection of tissue here that looks slightly different. And then the question comes, is that a new growth of cancer? Is that a scar from a prior inflammatory process? Is it clinically significant or not?
Now, do you find these advances in technology sometimes take the place of establishing a doctor patient relationship? For instance, in the emergency department where it's so busy, do you feel sometimes it's easier to send a patient off to a scan rather than taking the time to do a careful history and physical?
No doubt about it. In most busy emergency departments I worked in, the nurses were actually deputized to send a patient over for CT scan of the brain if they thought it was necessary. And many of the times they made a wise decision, but quite a few times they scanned a patient that I would not have, and then they get an incidental finding, that now I have to take the time and call the radiologist and say, is that in this clinical setting of what happened to that patient, is that significant? And often the answer was no, that's not significant at all. I
Yeah.
understand it, and as a patient, then we get reassured when we get a high-tech intervention. More information seems to be always the best thing.
Now, how do you push back against that? You've been practicing for decades and you resisted the pressure to be more proverbially productive. You were able to maintain that connection with patients despite all the incentives that dissuaded you from doing so. How did you, as a physician, how did you push back against that?
We had to be confident enough in your ability to determine what's in the best interest of this patient at this time. And when you came to that conclusion, you had to keep an open mind that maybe you're wrong. So you're constantly second guessing yourself and evaluating, does this patient need this now or not? One of the things we had to do in emergency medicine, for example, if a patient came in with an injury, to institute a trauma alert, which activates the trauma surgeon, the X-ray department, the lab department, and everybody. It's like all hands on deck for this patient. And it wasn't until late in my career that I realized every time you do that, the hospital makes a bundle of money because then they can submit a charge for having activated a trauma alert. And sometimes it's just not appropriate. So I would make my own decisions, and I often caught grief because having worked as long as I had and having worked in the years before CT scans, I got fairly confident in my clinical judgment as to what the patient needed. And again, I constantly have that gnawing, nagging. So it's sometimes easiest to just go with the program, which is okay, yeah, call a trauma alert, and then I can stop thinking the patient's going to go over and get a pan-man scan, we called it, where they get scanned from their head down to their pelvis. Doesn't bother to include the extremities in the emergency department. It's easier for me to just say, yeah, do everything, and then let somebody else figure out what's important. And I was fairly resistant to doing that since I'm kind of a stubborn individual. And it was important for me to do what was best in the best interest of my patients.
So, in the years since, this reliance on technology and a focus on productivity has only increased. Now, of course, we have things like private equity buying up a lot of emergency departments and physician clinics, and there's just much more of a commoditization of medicine, and much more, like you said, focus on productivity. So, for those physicians who are still practicing and those physicians who are newly entering the field, what kind of advice do you have for them? Because the pressure to go against what you're saying and resist some of the temptations to be more productive is very hard to push back against.
The pressure is enormous, and it's totally enormous. And I'm sympathetic to anyone who, in that stage of the game where they're trying to learn when to rely on your own judgment, and you need to always listen to all points of view. The patients obviously was equally important, and but your colleagues, if they think, gee, well, I mean, I worked with emergency physicians who, anytime somebody came in with chest pain, that was an automatic admission to the hospital, which I considered a basically not meeting your duty as a physician. If you sent everybody, if you got the hospitalist or the primary care doctor to admit every patient with chest pain, well, then you would never make a mistake. You would never miss anything, but you would generate charges for that patient. You would put that elderly patient in the hospital susceptible to contracting a hospital-acquired infection, which might be difficult and more dangerous than the thing they came in with. So you have to develop your own confidence in your abilities, yet at the same time, be of two minds about it. You're constantly trying to develop confidence and know when to proceed with what things with patients. At the same time, you're constantly questioning yourself: am I making a right decision now, or am I being too cavalier? I think
That
that's why even why physicians are experienced burnout. Those of us in emergency medicine have the highest rates of burnout at 63%, because that constant pressure of trying to make the right decision on behalf of your patients, it's difficult to live with.
so where do you see us going? The trend does not look promising.
Not
Do
at
you
all.
see any hope in the coming years?
I do. I'm a perpetual optimist, despite all the evidence to the contrary. That in my book, I refer to the process of healthcare going to hell in a handbasket. It really is, and we need to basically rejuvenate the patient-physician relationship as the key interaction in healthcare. And money works against that. The consumer provider model is basically wants to declare the patient-physician relationship dead. You don't really need a physician. You can have a mid-level provider, a non-physician provider, and you don't need to really consider which test to order. Just order a lot of tests, and we'll figure it out after we get the results.
We're talking to Drew Remignanti. He's an emergency physician, and today's KevinMD article is High Tech Should Not Replace High Talk and High Touch in Healthcare. Drew, as always, let's end with some take home messages that you would like to leave with the KevinMD audience.
For patients, and I've been a patient myself. I was a patient. I've been a patient longer than a physician. I have a 50-plus year career as a chronic autoimmune disease patient. You need to think of yourself not as a consumer of healthcare. You can be a consumer of healthcare information, if you want to call that consumption. But you need to find a physician whose judgment you can trust, who you know that person well enough to trust their judgment, and you feel known by them. Because, as I quote in my book, study after study shows that patients who become more informed about their own healthcare play an active role in their healthcare. They become more informed, and then they can participate in creating a treatment plan for that condition. Subsequent to that, doing those two things, then you are more adherent to that plan because you feel ownership of it, and the payoff is enormous. The mortality rate risk is cut in half for patients who follow that program of being more educated, more involved, and more adherent. So that's something we can do as individual patients starting overnight. We can decide today I'm going to become a more knowledgeable, more engaged patient in the relationship with my partner, with my physician in addressing my healthcare concerns. This is a book that I wrote on the basis of my 40 years as a physician and 50 years as a patient, raising the healthcare interaction to a partnership between the patient and the physician. And I think it's hard to, when I talk about these concepts, I want to say everything that I put in my book, which obviously I can't. I think it gives a much more rational and gradual explanation of the points I'm trying to make.
Drew, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
And Kevin, thanks again for having me.